So I have three kids. I have Grant, Marlo, and Cole. Grant's my oldest. He's my athlete, and he's either reading or playing sports. Marlo is a little bit more creative. She's 6, very precocious, also a bit of a reader. And Cole is into construction. He makes things, including using tape and various materials to create little scenes in the house. So I have three very busy, very creative, and fun kids. I sort of see myself as living this sort of double life, but each sort of adds to the other. And so I'm here, I'm 100% in with my patients, using my most attentive, creative skills to create the prosthodontics that my patients need. At home, I'm using my mind and my hands and my words to keep those kids learning and growing. And so the amount of care and attention to detail and patience it takes to be a parent, I also find it takes to be a prosthodontist. And I have learned to use those skills in both roles. Well, I actually have decided that it's a really great way to show other doctors what I'm able to do, but also I bring a lot of humility to my presentations. I show them the things I struggle with. I show them the cases I found difficult. I also engage with the patients when I ask their consent to use their material. And I say, listen, this is a really great example of X, and may I use this in my lecture? And I'll take the photos and prepare the lecture material in a way that is kind to the patient and in a way that, protects their privacy and security, but also allows me to take the things I learned from the case and to teach others and also gain some insight into why we do things the way we do them. And so spending that time, in the preparation process is almost as valuable as the time I spend on the podium, because it really takes the patient and their consent and my research and my attention to detail, as well as the people I engage with while I'm lecturing. It brings everything together in a really nice way that provides a bit of thoughtfulness to the practice that I think doesn't necessarily come when you're doing the busy day-to-day patient care stuff. The hardest treatment plan can sometimes be the plan where the patient requires a full reconstruction, but they may not be emotionally or physically ready for it. When I see the beginnings of very severe dental problems and I explain to the patient that you're getting to a point where you might need a very significant intervention, it may not be now, but it may be in 5 years. We need to work with your biology. We need to work with the dental materials we have to try to maintain your teeth as long as we can, but you may be looking at a full mouth of implants. You may be looking at a full mouth of crowns to restore health to your oral cavity. When I have to explain that to the patient for the first time, it's often a very sensitive and tender discussion, because I know that the news that you'll need such involved care can be very hard. So I often will take extra time to explain to patients, we're going to do everything we can to biologically keep you healthy and also start thinking about the future. So the biggest way I employ technology related to surfaces is, of course, in bonding procedures and being able to preserve as much tooth structure as possible when restoring teeth, whether we're restoring them for function, restoring them because of dental decay or caries, cavities, or restoring them for aesthetic improvement. We want to use the materials that will last and also will age with the patient. They will age at a similar level as their natural dental tissues. And so what I'll be able to do is keep as much of the natural tooth structure as possible, provide very conservative dentistry, bond it in a natural way so that all of my dentistry looks very natural, like enamel that was never missing in the first place. I use lithium disilicate for almost all of my crowns and veneers. I do use porcelain fused zirconia. I do use lithium silicates. I use other feldspathic ceramics as needed. When doing material selection, I often will engage with the patient so that they're aware of their choices, and I'll explain to them what the pros and cons are as needed. So lithium disilicate is a very high strength ceramic. I often say it's actually not a ceramic, right? It's a lithium oxide with a silicone component. So it's not actually ceramic. It's very strong, it's etchable, it's bondable. And so for the veneers that I provide for patients in lithium disilicate, I'm very confident that long term they'll have minimal problems with fracturing or decementation because of this bonding and etching technology. I do offer patients feldspathic veneers from time to time, which are the traditional sort of glassy silicate ceramics. They may be more translucent than some of the Emax veneers, but by the way we can stain and glaze the Emax these days, there's almost an imperceptible difference. And so when explaining to the patients their options, sometimes they come in with research explaining that they want feldspathic veneers and this is why, or they want Emax veneers and this is why. I always love to have that discussion. Of course, sometimes it depends on the patient's anatomy, their bite, and their expectations as well, or how much of the tooth structure we're restoring. I am so fortunate to have a treatment planning coordinator and front desk staff that really understand what I do and they understand the value of the care that I provide for patients. When we start a case, some patients are often surprised by the overall cost of care. And what I like to explain to them, and the treatment planning coordinators know this as well, is that even though the overall cost may seem very high, what comes with it is several rounds of teeth. So I often will plan the case in wax first, and then I'll build it in plastic. The patient may have several try-ins where they see their ceramic teeth before they're stained and glazed. They might see them another time when they have just the initial stain and glaze, and we're deciding about the characterization. So having a front desk staff that understands that a patient is not simply getting some crowns or veneers, they're getting a wax-up design, they're getting a plastic design, temporaries that will serve them as long as they need in terms of additional procedures. Sometimes they'll need gum grafts with Dr. Nevins, or sometimes they'll need a root canal with Dr. Cooper. Having the full comprehensive care model, we're able to provide patients everything from top to bottom. And so when a front desk coordinator such as Monique or Shannon or Liz can explain to the patient the amount of work that goes into the process, even something as simple as 6 veneers or crowns, it really helps the patient understand that what they're getting is something truly special. So my career path has been a very targeted one, a very intentional one. When I decided to go to dental school after taking the MedCat and thinking about applying to medicine, I ultimately figured out that my best skills were really those that were very technical. I liked using my hands. I knew I was good at visualizing and executing very intricate procedures. And so the way I would serve the world would be to perform dentistry and prosthodontics. So once I went through Harvard Dental School, where most of the students specialize, I found myself in love with prosthodontics. I really knew that I would be able to spend my days waxing teeth, doing ceramics, understanding complicated problems, trying to recreate nature in patients' mouths as a way to, really use my skills and fulfill my career. And so I went straight from Harvard Dental to a residency at University of North Carolina, Chapel Hill, where I learned a lot of complex prosthodontics serving the state of North Carolina, maxillofacial patients, everything from full mouth reconstructions, crowns and veneers, to full arches on implants, surgery. And so coming back to Boston, I knew that I'd have the skills necessary to complete dentistry at a very, very high level. Many general practitioners are very talented and can perform many of the procedures that prosthodontists do perform. However, I knew that my training was necessary to allow me to practice in Boston with Dr. Nevins and the team here. I've been with Dr. Nevins since the summer of 2018. I know because I count in years my daughter is, and she was born in the summer of 2018. I could not imagine working any other way. My first couple of jobs were interdisciplinary, interspecialty, and finally finding a partner who really has my same expectation of excellence, degree of attention to detail, someone who will sit with me and look at every case like it is the most important case that has ever come before us. I found that in Marc Nevins, and it really has been an absolute dream come true as far as my working environment. And as we've added to the practice, Dr. Cooper, who I knew since dental school, Dr. Amini Solari, Dr. Smith, it is a way for us to really treat every patient with full interdisciplinary eyes to give them the best outcome possible. I love digital smile design because it allows me to spend time with the patient to get them excited about what I can do for them. So the digital part is actually what I consider just pre-phase of treatment. It just allows me, the patient and I, a framework to discuss what they expect their teeth to look like, what I consider appropriate size, shape, and teeth to be for them, and figure out how we can get our visions to align so that the thing that I do for the patient when we actually start physical treatment meets their expectations and also meets my expectations as far as longevity, natural looking teeth, and giving the patient what they want. I always tell patients that as much as I work hard, I also want my dentistry to disappear. I don't want patients to look like they've had any dentistry done. I want them to look like they have really awesome teeth and they're just genetically lucky. So even if I don't get to show off by saying, well, this is a patient I treated, it's nice to have the message of, I want it just to look like you have healthy teeth and people to say, wow, you must have just had good genes. I think that's really exciting technology because particularly for the edentulous patient or a patient with truly failing teeth, it may allow us to use anatomical landmarks or markers based on their skeleton to put the teeth back into where they would have been 30 years ago or before periodontal disease caused the loosening of the teeth and the overeruption. So I like the idea of using technology as much as possible to create for the patient their ideal dental situation. But of course, this is again pre-treatment planning. This is something we like to do in the beginning that informs our decisions as we go into the physical wax up, the tooth preparation, the plastic, the temporary phase, which is so critical, and the final reconstruction.